Okay, our next speaker is Dr. Wizdom Powell, who is the Director of Health Disparities Institute and Associate Professor of Psychiatry at the University of Connecticut. She was appointed by President Obama to serve as a White House Fellow to Secretary of Defense in 2011 to 2012, and in this role she provided subject matter expertise on military mental health like PTSD, suicide, and military sexual trauma. Dr. Powell?
Good afternoon, I think. So I'm here today in my capacity both as a psychologist, as a daughter, as a granddaughter, as an auntie of boys and men who I love dearly, and also as the chair of the American Psychological Association's working group on health disparities in boys and men. And today I'm going to talk a little bit about the context surrounding the issues that we're talking about today. Next slide. Before going forward, I think it's important to acknowledge the other members of the APA Working Group on Health Disparities in Boys and Men. This is an interdisciplinary group of scholars, experts from across the country who have come together all to collaborate on solutions both for policymakers, for clinicians and practitioners, and also for scientists. Next slide. So I want to start this conversation out with a warning that was offered by Chimamanda Adichie, who warns us of the dangers of a single story. And she talks about single stories as being dangerous because they tell incomplete and isolated truths, that they flatten lived experience, and that they emphasize the stereotypes. And why start with this warning? Well, one of the reasons it's important to start here is because I believe that we've been having a fairly narrow discussion across the country about boys and men. Next slide. Even as a woman who believes wholeheartedly in gender equality and equity and the advancement of women and girls, it is really hard to look at the growing public discourse around boys and men that both problematizes them and pathologizes them, and at the same time renders their interior lives relatively invisible. The truth is that boys and men in our nation are in a crisis, but this crisis is unfolding amidst a widening empathy gap. Next slide. All around us is compelling epidemiologic evidence suggesting the need to disrupt these single stories. Compelling evidence, for example, suggests that despite having more social power than women, men in the US are more likely to experience premature death from conditions amenable to early detection. And so the whole story that needs to be told is one that indicates that over the past 3 decades, we've only made modest progress in reducing sex differences in key health outcomes. Next slide. Supporting the need even further for a more holistic story is the frequently discussed paradox in mental health. That is, while men tend to report less depression than women and to be diagnosed with depression at lower rates, they also have higher rates of suicide completion. Next slide. A whole story about boys and men would state that while it is true that women are at higher risk for opioid addiction, it is also well known that many more men in the US perish prematurely from overdose deaths, including deaths from opioids. Next slide. What was curious to us at the working group is that largely absent from our stories about boys and men is that at the very early stages of life, boys are more negatively affected by early environmental stress, both inside and outside the womb, and that, as research suggests, girls have more built-in mechanisms that foster a kind of resiliency against stress. Even when we look at the lower PTSD rates that we see among men relative to women, men are more frequently exposed to traumatic events. And the highest rates of opioid use disorders among individuals reporting traumatic events and exposure with a correlation with PTSD happen among men. But even if our hearts and minds aren't moved by the call to tell wholer stories about boys and men, perhaps evidence about the economic cost might compel action. The World Economic Forum describes hidden costs of diseases and suggests that mental health disparities like the ones we're observing among boys and men in the US increase healthcare spending, depletes human capital, diminishes worker productivity, and impacts our economic growth and aggregate outputs. Next slide. And there has been ample research suggesting that mental health problems also impact labor force participation. On this slide is a graph showing data that suggests that over the past 6 decades, there's been a slow decline in the labor force participation rate of men, especially those between the ages of 25 and 54. Next slide. But alongside this evidence, we have some compelling new data that suggests that nearly half of the working men not in the labor force report daily opioid use. So why might we be seeing these consequences? Well, we know some things about health disparities in boys and men from psychological and social epidemiologic research. The first is that males have a more difficult time labeling and detecting emotions. Very early in the life course and very early in the socialization process, boys are not taught to identify and distinguish between anger and shame. Males are also reluctant to disclose physical and mental health problems, and we know from compelling national evidence that males delay health screenings and wait longer to seek acute medical and mental health attention. But boys and men are not hardwired biologically to delay mental health signs and symptoms. In fact, we know that a large part of what we're observing in their behaviors are socially determined. And even with all of the attention that we've paid to mental health disparities in boys and men, there's still a missing piece of the puzzle. Next slide. And that missing piece of the puzzle is the limited focus on the role played by inequitable distribution of power, opportunity, and social determinants that uniquely compromise the mental health of socially disadvantaged boys and men. So we started this journey, next slide, with reframing, this is fine, mental health disparities in boys and men. And we made some key assumptions that I think are relevant to our conversation today. The first is that the risk for health disparities form in childhood and continue as boys and men age, as we heard from our first presenter. And that while genetics and individual health behaviors are important, disparities in mental health are primarily determined by social conditions in which boys live, work, play, grow, get educated, and get health care. Next slide. We also reframed this focus on mental health disparities and other health disparities in boys and men to zero in on stress. And we see stress as a fundamental or root cause of mental health disparities and physical health disparities among boys and men. And we suggest in our report that stress affects the mental health of boys and men directly through physiological pathways and indirectly through health behaviors and decisions. Next slide. It was also important for us to view these issues through a gendered lens. And what do I mean by that? Well, we talked a little bit this morning about the pressures that boys and men are under to be a man about their issues, to respond to stressors in ways that display physical and mental toughness. On every playground across this country, we can find a mother, father, or a social mother, a father, saying to a young boy, walk it off, after he falls down on the playground. These messages, like boys don't cry, take it like a man, have an enduring effect on men's capacity to disclose vulnerability. And we know from emerging evidence that men who adhere rigidly to these definitions of masculinity also report more substance abuse. Next slide. But I think that even as we talk about masculinity, it's important to realize that masculinities are multidimensional, plural, and situational. So as we're talking about substance use and mental health as a consequence of toxic masculinity, I think it's important to recognize that masculinity is referred to what men and boys do moment to moment and and from situation to situation. It's not rooted in biology or personality characteristics. These are social constructions that we all are complicit in maintaining. We recognized in our working group that as we're talking about masculinities, gender, and mental health, that we are observing pronounced disparities among boys and men who have not had full and equitable access to opportunities for securing socioeconomic power and stability. And that's even in contrast to other males in the United States. Next slide. So we focused in our report on these groups of socially disadvantaged boys and men, particularly paying attention to racial and ethnic minority men and men who have sexual minority status. Next slide. Why focus on racial and ethnic minority males at a time when it seems that we need to be talking about all boys and men? Well, there is compelling evidence to suggest that our suicide rates are consistently higher among American Indians and Alaska Natives, particularly because this group faces unique stress and trauma associated with their place in society. Next slide. We are also seeing recent increases in suicide rates among 5 to 11-year-old Black boys. And this is despite years of Black boys having lower suicide rates in our country, some of the lowest. And even at a time when we see the rates of suicides decreasing in non-Hispanic white males. Next slide. An even more compelling reason to talk about this in the context of the opioid crisis is because the steepest escalations in drug overdose deaths have occurred particularly among non-Hispanic Blacks between the ages of 45 and 64, and yet the dominant discourse has done very little to include this population. From 2012 to 2015, for example, cocaine overdose deaths were almost as common in Black men as prescription opioid deaths in white men. Next slide. We also know that sexual minority boys and men are at heightened risk for bullying and harassment, and they are more likely to experience mental health problems and to be at risk for substance abuse and dependence when compared to their heterosexual counterparts. Sexual minority men and boys are also victims of hate crimes that can increase their risk for substance use and abuse. And so we make some recommendations in the report, next slide, that we think might help to counterbalance these issues. The first recommendation is that we leverage policy opportunities to expand programs that can assist boys and men who are returning or re-entering communities from prisons and jails. This includes providing masculinity and trauma-informed care and services while men are incarcerated and after they are released. We need to harness every policy opportunity we have at our disposal to expand behavioral health care access and coverage for boys and men. After Medicaid expansion, we witnessed an uptick in insurance coverage among childless men, which represented it for our nation the first time that we've been ever able to expand coverage to this population. We need to redress child welfare programs to support father involvement in the socio-emotional development, not just the financial contributions among their non-residential children. Next slide. We need to begin providing training to psychologists and healthcare professionals and providers working with socially disadvantaged populations to incorporate comprehensive assessments for mental health screening and primary care. We need to flip the clinic so that we're providing opportunities for men to seek care at non-traditional hours, like on nights and weekends. And we need, most importantly, to provide implicit bias and trauma detection training for every person that touches the lives of a boy or a young man developing. I just want to leave you with some just final thoughts, because I'm at time. Because I think I started with the single story, so it's important to end one. I am the granddaughter of a Korean War veteran who died prematurely at the age of 53 from a preventable cancer that was linked to substance abuse and addiction. And when he died, so did a part of my family history. And so many opportunities for intergenerational learning were also diminished. And so I know firsthand what it looks like to be on the receiving end of the premature loss of a boy or man that could have been saved or helped by social structures and programs and policies. And so I think we have an opportunity now and the knowledge to disrupt these single stories and to do what we would want anyone to do for the children, the men in our lives that we love and care about. Thank you.
Are there any quick questions for Dr. Powell? Yes.
I'm Andrew Sanderson. I'm the medical officer for the Office of Minority Health. You talked about the increases in suicides for black males from the ages of 5 to 11. We know that adverse childhood events can lead to more disease later in life. The other speaker talked about early childhood stress or early life stress. Is there an age at intervention or screening or assessment that the APA recognizes would be beneficial for children to try to prevent this or to identify it early?
That's an excellent question. I can't say with specificity we've pinpointed an exact age, but I can say that we have been advocating for earlier interventions for boys and men and for other children who may be at risk. And I think that whatever we design, it has to be designed with a life course developmental lens applied. We know that there are specific brain maturation, identity development issues that happen at different stages of the life course of our youth. And I think that if we were to develop strategies, they have to be aligned with what we know about development. It's often been the case that we have policies on this side and life course developmental specialists sitting on this side, and they rarely ever talk to one another. So I think at the very best, if we were to bring more developmentalists to the table as we're thinking about policy solutions, and really start to tailor our interventions to be more life course appropriate, I think we would have better outcomes.
Well, my talk's going to be about that. So
Okay.
So, more to come.